welcome everyone to the Society of Thoracic Surgeons Congenital Heart Surgery Database monthly webinar. Today is Tuesday, January 21st of 2025. So welcome everyone. Welcome. Happy New Year. If I haven't talked to you since the beginning of the new year. So on the agenda today, we just have I have a super brief STS update, not a lot of new information from our December webinar. And then I'm going to turn things over to Chastity and Leslie for our data manager education. And as usual, we'll finish up with our Q&A. Again, just please be sure to use that Q&A function. We also have the raise hand function enabled. So if you would like to just speak and ask your question, we'd love to hear your voice. Just make sure that your microphone is enabled on your end. On the call today from the panelist side of things, the STS side, we have myself, Emily Conrad, Banu Yatsi, Carol Crone, Paul Meehan, and from our consultant team, we have Chastity and Leslie and Melinda. We also have Nancy Honeycutt on the call. She's, I saw you sneak in there, Nancy. So, and then Dr. Meyer has graciously joined us today. So thank you, Dr. Meyer, for joining us. All right, let's go ahead and hop into our STS updates. Just a reminder that the training manual was posted earlier this month and is available for your download if needed. The 2025 harvest schedule was posted. Our spring 25 harvest is underway, and that is scheduled to close on March the 21st. And after the close of our spring harvest, we'll immediately begin, accepting data for our fall 25 harvest. And that fall 25 harvest schedule close date is September the 26th. And again, that harvest schedule is posted and available out on the STS website. For the primary procedure mismatch report. So we do have an update scheduled to come out, scheduled for release for the primary procedure mismatch report. As discussed in our November 2024 monthly webinar, we do have a new process that was effective January 1 of this year. Just a reminder that this new process is basically replacing the exception 1, the PSF rule. That new rule will be implemented with the spring 25 analysis. So if you need a refresher, please, I encourage you to go back and review the November 2024 monthly webinar, as Chastity and Leslie did a phenomenal presentation on the new process that is taking place. And again, if you have any questions, about this, we're, happy to answer those. Also, please submit questions to the FAQ if needed. But again, I just encourage you to go back and listen to that November 24 monthly webinar, as Chastity and Leslie provided an excellent presentation on this new process that took effect January 1. Also, for those not aware, just wanted to let you know that the CHSD risk-adjusted report calculation resource document was updated in December of 2024. So if you do utilize that resource, or if you're not familiar with that resource, out on the IQVIA platform, let me pull this over. Out on the IQVIA platform, within the library, there is this document here called the CHSD risk-adjusted report calculation resource. So if you do utilize that, or if you don't utilize it, just wanted to show you, for those of you that are not familiar with this document, just wanted to show you this resource. If my computer is doing some really odd stuff today, so I apologize. I don't know if I can get it to open. That's not that document. Don't say that. I cannot get it to open. Okay, I'll try and come back to that if I can get it open. But again, just that risk-adjusted report calculation resource has been updated. So again, if you did download it, just make sure you have the most current version. All right, with that, I'm going to turn things over to Chas and Leslie. Leslie, the floor is all yours.
Great. Thanks, Leanne. Hello, everyone. Hope you all had a nice holiday season. For today, we are going to treat this very much like sort of a update, a summary of some of the changes that we've seen. So we're gonna start with just that, a status update, changes we saw in 2024, what's new in 2025, and then what's coming ahead. We are gonna review our FAQ process. There's been just a couple slight changes to how we're working things, review and kind of reminders. We're going to touch on a couple of updates that hit the January training manual. And then Chas is gonna get into fundamental diagnosis, how we should be using that, what it means, and share some tips and tricks. Next slide. So starting with changes in 2024, we had two changes to sort of how we collect data that were rather large, or at least large in my head, how we think about our data. One was to how we are counting prior operations. This refers to sequence numbers 2000 and 2005. It's both previous cardiac operations and previous cardiac operations on pump. This is all explained in the training manual on page 650. I have linked the webinar where we talked about this in detail, so if you download the slides, those should work for you. With that change, how we previously counted, or I'm sorry, how we are counting prior ops now, the audit criteria also changed. So audit used to look at exactly the number of prior cardiac operations. Now they are looking at whether or not it's zero or greater than zero, which matches how the field is used in the risk model. So we're excited about that update. Next slide. The other big change that we saw in 2024 was introducing our optional limited data set for adults with congenital heart disease for their non-index operations in the database. Again, I've linked the webinar in which we went into the full detail of how this works, but it's also described on page 5 of the January training manual. And this, just in brief review, gives you the option to collect a smaller number of fields on non-index operations. We, of course, recommend you talk to your sites and determine which of the fields you will or won't want to continue to collect. But again, it's all described in the training manual. Next slide. And then just one more update for something that happened to the webinar. After all of your feedback, the webinar previews are now showing a picture of the educational update agenda. So the part that Jas and I touch on, like today said, status update, FAQ process, fundamental, that's what you should see for the webinar preview. So hopefully that helps to just sort of direct you in the correct area for what you're looking for. But please keep that kind of feedback coming. I think that's a wonderful suggestion, and it helped me find these old webinars much quicker. Okay, next slide. Moving on to what's new in 2025. Again, I've linked the webinar, but as Leanne touched on, we did have a pretty big change to how we're going to determine primary procedure, starting with cases beginning January 1st, 2025, but it will apply retrospectively in our spring harvest. So that's the report that we're going to see hopefully next month, live for all of us. That will show us if the primary procedure will have changed based on these new rules, and so that you only have to go in and review those cases. It's not super helpful, but it refers to primary procedure sequence 1355. Again, I linked to the webinar, and then this begins on page 546 of the January training manual. We are hoping to get that bookmarked in the training manual because it's quite a few pages. Okay, next slide. And then the other major change was how to use VAD op types. So the change here is that sites are required beginning January 1st, 2025 to submit all VAD cases. In making that requirement, the surgeons, the core group, the task force felt it was important to better define what these op types are and how to use them. So again, we went over all of those details in the December webinar. It is listed under the VAD op type definitions in the January training manual, beginning on page 615. Next slide. Okay, and then what's coming ahead? So Chastity and I are going to bring back new data manager training this year. We touched on it a little bit last year within this webinar series, but we want to have a standalone webinar in 2025. We expect this to happen annually, and we are really, really hoping we can get our first one out in late February, so it's ahead of our next harvest deadline. In that, you can expect to kind of high level basics, but go over all of the resources that are available to you, how to do this work kind of day to day, how things run, what a vendor is, what direct data entry is, what it means to submit your data, what the reports look like when you submit your data versus when you get an analyzed report, all of those kinds of things at a high level, we will dive into in that series. So more to come there. Next slide. We also want to have likely also annual a report overview webinar. And this will be how to actually read those analyzed reports. Again, we'll touch on the resources available to you, including that calculation spreadsheet that Leanne mentioned, what all that means, what the tabs mean, how and when that's updated, how it is alike and different from the analysis overview document, and kind of how to use those to the best of our ability. We'll teach you how to use those, and then also just how it can help you moving forward in your role. Next slide. Oh, sorry, that one we expect to roll out following the next report release. So the deadline is like mid-end of March for our spring harvest. If we get those reports back, say in April, we hope to have that report overview webinar then maybe late April, May, following the release, so we can go through what those reports look like. Okay, next slide, sorry. All right, so just a review of our FAQ process. As you all know, we really need you to submit all clinical questions to the FAQ mailbox. It is also linked there. You'll select the applicable version. Right now you have the options of 341 or 623. Those options will remain there until we either are no longer submitting 341 cases or we've moved on to a new version. Questions are generally answered within 30 days. We're really trying to stick to this. Chastity and I do meet weekly to go through anything that we've answered before or pretty straightforward already in the training manual, those kinds of things, or triage if we need to go back and forth to get extra documentation like op notes or echoes. But we are really trying to stick within that 30 days. I think we've done a good job over the last couple months, but we appreciate you sending those in. And then next slide to clarify, the answers that were given out are specifically for your question that you sent in. So if you send me a question and say, here's what my case looks like, how do I code X, Y, and Z? And we say, great, code it this way. We really don't want that generalized to all of your other cases. Even though it might look similar, if it's not clear in the training manual, please submit a new FAQ. We really spend a lot of time going through op notes, echoes, discharge summaries, whatever it is, to make sure that we're giving the best answer for the case. And we don't want those, you know, applied to cases that aren't exactly like that one. That's one of the reasons we're not putting all of those case scenarios in the training manual anymore. Next slide. But if it is a generalized question, we will make clarifications and we will post that to the training manual monthly. More than likely, you're going to see your answer, and then the next month you'll see it updated in the training manual. However, sometimes we need to get approval or clarification on the language we want to use to make sure that we're not creating further problems down the road by how we want to describe something. So it can take a little bit longer, but as soon as you get your answer back, you're free to go ahead and save that and reference it if you ever need to in case of audit or whatever it is. Once it hits the training manual, of course, then it's out there and available for everyone. And just to be clear, again, we never expect you to go back and change cases from years ago. Always, if we make a clarification, it's just from now, this point forward, we've clarified and just move forward with those extra details. Next slide. Similarly, we don't change definitions. We don't change what a field actually does or doesn't include in between versions. And that's because, of course, we don't want to have to go back and recode all of our cases. So we don't want a bunch of people doing it all different ways mid-version, with the very rare exception when the task force might actually mandate a definition change. And in those cases, you'll see a large webinar, lots of education on it. and pretty clear dates and definitions of when that happens or how it happens. But again, that's pretty rare, and we do everything we can, at least Chastity and I do everything we can to really discourage any kind of changes like that in between versions. Next slide. Okay, and then updates to analysis might occur between versions. Those will occur at the time of harvest. That's similar to like the primary procedure. Primary procedure still means what it means. It is the procedure that will be analyzed, but we are looking at it in a different way. That will be beginning, for instance, this spring, and it almost always applies retroactively. I don't know if, or retrospectively, I don't know if we'll ever see it just start and go forward, but one can hope. Next slide. Okay, while we're on FAQs, we did make a couple updates to the training manual above and beyond all of the details for primary procedure rules and VAD op types. We also clarified the field for shock resolved within 24 hours of surgery. This is sequence 650. So it previously said was shock resolved within 24 hours. And the questions that came in were, does this mean, was it resolved within 24 hours? Or does this mean, did it resolve? Did the resolution resolve or come within the 24 hours before surgery? So we added the red that you see here. If shock resolved at the time of surgery, indicate if the patient's shock resolved within 24 hours. In other words, did the resolution of shock occur within the 24-hour time frame prior to the patient entering the OR? So what we're getting at is, was this patient in shock recently and it resolved within the last 24 hours, or were they in shock 2 weeks ago and they have since not had further episodes of shock? Next slide. We also included another example of when, an example of when you would say not just yes in the first example, but when you would say no. And those are both described in the January training manual. Also of note, if you search Jan-25, you'll see all of the updates as well as in that FAQ summary document. Next slide. And then an update or clarification as well to procedures 3820, 3830, and 3840. This is right, left heart temporary assist device for implants, explants, and procedures. And this is really describing if the interventional cardiologist is the one who does the procedure. This is going to be treated very much like our hybrid procedures, case type or op type 777 or other. And your primary procedure will be the access the surgeon provides. You'll also list the appropriate temporary assist device code, and you can still open the VAD section and put in any details there. But the primary procedure is what the surgeon did, which is the access they provided. Next slide. And then just of note, I copied this out of just one of those clarifications, but it applies to temporary assist device implant removal, or if they perform a procedure. Okay, next slide, I think turning it over to Chess.
Excellent, Leslie. Thank you so much. Great overview. So I know that Leslie and I have received many questions in the FAQ box regarding fundamental diagnosis. So we wanted to make sure that we called out some highlights, and this is not a clarification to what the definition of fundamental diagnosis is. There's no change to the definition of fundamental diagnosis. We just want to make sure everybody understands and that we're all on the same page as to why we code the fundamental diagnosis and what it is. So as stated in the current definition for fundamental diagnosis, it is defined as the most complex cardiac anomaly or condition of the patient, and it will remain with the patient throughout their lifetime. So I make it sound so easy. I really look at this as the transaction of art and science, right? Like sometimes it's just not cut and dry. It may be more of a gut feeling, but hopefully we can give you some more guidance towards this. So remembering that the fundamental diagnosis will then span all operations and subsequent admissions to the hospital. So the fundamental diagnosis then should not change when a patient comes back in for another surgery. The fundamental diagnosis can be congenital, meaning it's present at birth or you were born with it, even if the diagnosis wasn't made, or it can also be an acquired condition. So thinking of some of our traumatic cardiac injuries or cardiomyopathies that might be induced by a medication or perhaps an exposure of some extent for a patient. And remembering that when a patient comes in to have surgery, this fundamental diagnosis may or actually may not match the primary diagnosis. So it's very important that you're coding the fundamental diagnosis correctly. Even though the reason the patient is going to surgery, that primary surgical diagnosis may differ every time the patient comes in for another procedure. Next slide. So that being said, let's look at the differences then between both the fundamental diagnosis and the primary diagnosis. So both can be congenital or acquired. They may or may not match one another every time a patient comes in to have a procedure, but remembering in the fundamental diagnosis, it is the most complex lifelong diagnoses that will stay with the patient and will not change with subsequent operations or admissions to your facility or another facility. Whereas the primary diagnosis is that primary reason for performing the operation that day. And this may change with every subsequent operation or admission to your facility or another facility. Next slide. So let's go through a brief example. A patient was born with HLHS with both mitral and aortic stenosis, and they undergo a Norwood procedure with sono shunt placement. They return at a later date with aortic arch obstruction, and they undergo repair of that obstructed aortic arch. So for the Norwood operation, your fundamental diagnosis from the information that you have here being the most severe, most complex lifelong diagnosis this patient has is 2790 hypoplastic left heart syndrome with aortic stenosis and mitral stenosis. The primary diagnosis for the reason that the patient undergoes the Norwood on that day is for that fundamental diagnosis of HLHS with aortic and mitral stenosis. Whereas when the patient returns later with aortic arch obstruction, we would still describe their lifelong fundamental diagnosis as HLHS with aortic and mitral stenosis. However, we would change the primary diagnosis. The reason that that patient is having surgery that day, I won't say change, we would code the primary surgical diagnosis of that day as diagnosis code 1000 aortic arch hypoplasia. Next slide. So a couple of considerations when you're trying to determine the fundamental diagnosis for your patient. Not all of the listed surgical diagnoses can be a fundamental diagnosis. And I know sometimes this is confusing. Sometimes we don't like this. Sometimes we think that there is an error. But just think of a few of these: 2150 ASD postoperative intra-atrial communication or 2130 shunt failure. Neither of these and both in the training manual state this, cannot be the fundamental diagnosis. Next slide, Liam. And if you think about this, if you are a patient with a shunt or a patient where we have created an interatrial communication, you have some underlying cardiac reason that you underwent either one of these procedures. And so that's why these can't be fundamental diagnoses. Now, of course, we know that there are other ones that have other reasons that they can't serve as fundamental diagnosis, and you're welcome to submit FAQs regarding those if you really feel that those are the fundamental diagnosis. We can't change it today. But everything is under review at the time of version upgrades, and all suggestions are then taken and talked about and considered. Next slide. So the next consideration when determining your fundamental diagnosis is you don't really want to use your surgical pathway to determine what your fundamental diagnosis is. And this makes sense because we know that there are complex two ventricle lesions that we may repair using a single ventricle strategy, whereas there are also single ventricle lesions that can be repaired with a BiV or 2V approach. But how would you ever know a patient had a single ventricle lesion and was able to go to a 2V approach if instead you coded this patient as 2V disease versus a single ventricle? And likewise the same, where you had a very complex form of, say, congenitally corrected transposition that had to be repaired using a single ventricle strategy, you would lose that piece that this patient was really a complex CCTGA that went down a single ventricle pathway if you changed it to a single ventricle diagnosis. So you want to leave out the surgical pathway when determining your fundamental diagnosis. Next slide. And then it's not determined by your heart at birth. Many babies, as we know, are born with quote unquote normal heart, but go on to develop or acquire conditions that are to be your fundamental diagnosis. So you see forms of cardiomyopathy that come about later in life, and that it could be related to an underlying genetic condition. It could also be related to medications or exposures that they have had that led to this cardiomyopathy, or even an idiopathic cardiomyopathy. We don't want to put in normal heart and see that then a patient got a heart transplant. That doesn't tell us anything about that patient. You also think of trauma, where we have diagnoses available for both penetrating trauma and blunt trauma to the chest. So we've all seen some type of, whether it's tamponade and bleeding or valvular problems with trauma. And so we want to capture as best we can what's going to be the underlying fundamental diagnosis for that patient now for the rest of their lives. And then this is also true of some infectious conditions. So we have myocarditis and endocarditis listed that can be fundamental diagnoses. My rule of thumb is if there is a diagnosis listed in our list, I would always pick one of those before I would ever use normal heart. And I have a very hard time even going back through my data. I can't find anyone that I've ever utilized normal heart on. I'm sure there's been one over time. I've been doing this for a very long time, but I can't find it in my last, say, 10 years of data. Next slide. So again, I make it sound easy. I know it's not easy. I submit my own fair share of FAQs to Leslie. But if the patient has complex congenital heart disease or multiple complex diagnoses and you just can't determine which one makes the most sense, work with your surgical team, with that patient surgeon, to determine what the best fundamental diagnosis is. And of course, you can also send an FAQ. And I think that this is really important for you to do. I get a lot, I actually submit a lot of these, and it's great to get the feedback from the core group or surgical team on what they think the best fundamental diagnosis is. It's also an education point for me. Next slide. So again, let's look at an example, which of course we received a couple questions on this in the box. And so that's where this comes from. A patient develops rheumatic fever and develops mitral and aortic valve stenosis years following their infection with rheumatic fever, and they undergo mitral and aortic valve replacement. Well, you know, if you attempt to code rheumatic fever, that it cannot be the primary or the fundamental diagnosis of an operation or of the patient. So what do you do now? Next slide. So you're really going to have to kind of at your own site determine which one, whether it's mitral or aortic valve stenosis, both required to be replaced in this example, as to which one will be your underlying fundamental as well as primary reason for going to the OR that day. In my mind, I like to select the valve that has the highest degree of damage or the highest degree of dysfunction. So whether that is, you know, maybe moderate versus severe stenosis, I might pick one valve over the other. I also would talk to my surgeon to say, which one of these do you think would require most lifelong care or follow-up? Because they may have a different answer than I came up with just the highest degree of damage. The valve that is the most severe will likely be your primary diagnosis. So the reason that that patient went to the OR that day. Your fundamental, I think it's fair to do either one. And so again, work with your surgical team to determine this. If you submitted it to the core group, I would be inclined to say that we would probably say if the mitral valve had moderate stenosis and the aortic valve had severe stenosis, we would probably say we would go with the aortic valve. But if your surgeon feels differently, that's a great answer too. Next slide. So in general, your fundamental diagnosis should not change with subsequent operations or hospitalizations. Now, you may have received over time with a very specific example where you have submitted a question to the core group and we said, yeah, okay, this may be one scenario in the whole wide world where we would suggest changing the fundamental diagnosis. But I'll tell you that most of the time we say, no, the fundamental diagnosis should not change. But when would you, what kind of scenarios would you ever really update your fundamental diagnosis? And I would say this is, maybe you look at your fundamental diagnosis and you say, I coded that 5 years ago very incorrectly. I would never have coded normal heart today, or I would have never coded whatever it is that you selected. I really think this patient has something different, and I didn't understand that back when I first started with the database. If you think something is incorrect, by all means, you are welcome to change it. We're not saying go backwards or anything like that, but you are welcome to change if you think you've incorrectly coded something. Maybe you have more information now to determine your fundamental diagnosis. So for example, a patient came in and had, a coarc repair. You listed coarc as their fundamental diagnosis, and 6 weeks later they come back in and they have a CT, and now all of a sudden you find out they have, some other crazy diagnosis that no one ever noticed during their initial coarctation repair. So I would again say you got more information and you probably incorrectly coded that coarc initially because you didn't have all the information available and there was no reason to go searching for some other undetermined heart disease at the time. And so that may be the case for where it would update. But I would say very, very, very rarely, unless you got it incorrect when you initially coded it, would we ever suggest that you would update your fundamental diagnosis. Next slide. So in summary, related to fundamental diagnosis, it is lifelong, should not change over time with subsequent operations or admissions to your hospital. It may differ from your primary surgical diagnosis or why they're having the surgery that day. It may not be present at birth, and it could be an acquired condition. And it may require you to further discuss this with your surgeon to adequately determine what the fundamental diagnosis is. So I think this is my last slide. Yep.
Yes, ma'am. Thank you, Chas Leslie, for excellent education per usual. We do have a couple of questions, just a couple right now. So let's go ahead and tackle those. Our first question's from Angie. And I think, Leslie, this goes back to your portion of the presentation. She's asking, what if they are persistently in shock upon entry to OR, ECMO, cannulation, etc.?
Yep, great question, Angie. Thank you for clarifying. The field that we were talking about today, about the resolution coming within 24 hours, that is a child of when you code the pre-op factor, shock resolved at the time of surgery. So if it's persistent at the time of surgery, then you would code the pre-op factor 230, shock persistent at the time of surgery, and you would not see this child field pop up. This is only going to appear if you have coded that it has resolved, and then we want to know how recently did it resolve. Thanks, Angie.
Perfect. Thank you for that clarification. All right. Next question, Chas, this is for regarding the fundamental diagnosis. Do you change the fundamental diagnosis when the patient has a heart transplant?
Great question. The answer is no, because the fundamental diagnosis will give you maybe the underlying most complex heart disease that the patient has that required them to have a heart transplant. So how many heart transplants do we do for a patient that has HLHS? How many heart transplants do we do for a patient with myocarditis? How many heart transplants do we do for a patient with cardiomyopathy? We would never be able to answer that if we were changing the fundamental to reflect the fact that now they've had a transplant. So we want to leave it whatever the appropriate, correct fundamental diagnosis is.
Got it. Thank you. And this next question from Nicole, which it's fine, Nicole. I know this question wasn't discussed today, and that's perfectly fine. So if you have any questions, please feel free to put them into the Q&A and we'll answer, any questions that we can. But can you confirm that a patient who has a primary procedure of surgical PDA ligation and weight less than or equal to 2.5 kilograms who died prior to leaving the hospital will not be counted towards op mortality? Or does that rule not apply anymore?
Oh, Nicole, excellent question. That rule does apply. So as long as it is the primary procedure of the operation and the index case of the episode of care, you are absolutely correct. It will not count towards operative mortality. You still complete the case as you would otherwise and complete all of the fields in total, but you are absolutely correct.
Thank you. And Nicole says, thank you, Jess. Okay. While we're waiting to see if any other questions come in, sorry, wrong way. Our next monthly webinars are scheduled for February 18 and March 18 of this year. So again, just mark your calendars. As always, our education team, our marketing team will send out a reminder email, but go ahead and mark your calendars for February 18 and March 18 at 12 p.m. Central Time. Let's see. Amy put in a question. Happy to submit as an FAQ, but working on this case right now where the patient with Wilms tumor who is receiving chemotherapy presents to ED and septic shock. Patient experiences brief cardiac arrest and subsequently resuscitated and transferred to PICU. Recommended patient be placed on central ECMO. I'm not, let's see here. She's just saying these are, I'm not going to read the whole thing. I know Chas and Leslie are reading along. These are the types of questions where I struggle with choosing fundamental diagnosis. It seems like a good example where I could code the fundamental as normal heart. I too rarely use this, but can't think of anything else aside from cardiac other for the shock that would be applicable.
Amy, I would like you to submit this as an FAQ just so we can make sure our definitions align with this. There is a choice of, and I may bungle the words, but it's cardiorespiratory failure not related to structural heart disease.
Yeah,
And
it's
so
something like
that
that. I was looking for it too.
Okay, that's probably what I would use in this situation, but please go ahead and submit this as an FAQ.
Yes. All right, perfect.
That would be great.
Let's see here, Kate, that is a great question. Has there been any communication to the surgeons regarding the primary procedure rule change? Let me check with the team. I don't think they have sent, I know it's been, discussed with the task force. Let me discuss with Jane and team, regarding that primary procedure. And then, if not, we'll definitely get something out, excuse me, right after, annual meeting. So thank you for that. Let's see here. Oh, no problem. Thank you, Kate. Let's see. And Liz, can you say more about the training in February? Would it be appropriate for new data managers who will be starting to code in STS?
Yeah, Liz, thanks. Great question. Yep, this is going to be for, so specifically we're saying new data managers, but we have found that data managers who've been here for years doing this also benefit from a new data manager training. We like to go through things at a kind of high level. It's similar to what we've done in the past where we've done like a back to basics and sort of gone through definitions. When we say all the time index operation, what are we talking about? What does primary procedure mean? What does it mean to harvest? Those kinds of things. So definitely if you're new, definitely if you've been new within the last year, I would say it'd be a great webinar for you. Or if you just kind of want a refresher, jump on. Hopefully you'll get something from it. If you don't, you might have some good feedback as a tenured data manager and say, hey, I wish I knew these kinds of things. So open to anyone, it's not restricted. And we will send more information as soon as we can.
Perfect. Emily, I don't know if you want to take this one. Do we have a date for AQO yet?
We have that in the works. I think we'll be able to announce information after the annual meeting, which is coming up in this weekend.
Yeah. So I know they're still getting contracts signed, and I think, obviously we'll share information with you all as soon as we are able to. But we just have to wait on our meetings team to get everything finalized and give us all of the final dates and information, and we'll share it as soon as we can. Thank you, Emily. Liz, great, thank you, sounds good. Amy, thank you for that question about shock in oncology patients. She's had a similar situation and selected normal heart. She hadn't thought about sending an FAQ. So yes, thank you, Angie, for that question. Excellent. All right.
Leanne, real quick, if I can, normal heart can be used. It's not that there's something wrong with using it. We're trying to say that if there is something more specific listed in the list of diagnoses and it is available for fundamental, we would recommend picking something more specific rather than just normal heart.
Right. Yeah. And
I see Marina's question as well.
Yeah.
if it's rarely used, why not remove it? I think it's a legacy. Chas and I were just talking about this. We're going to try to figure out more information on it, but it has been around forever because it's on the demographics table and the demographics live with the patient for their lifetime. We can't just eliminate legacy codes. It's possible that we revisit it and say, we recommend not using this going forward, but there are, I have a couple patients. I haven't found anything better. I like it more than an other code, so I don't know that much about it historically. But we do want to get some more information because again, we get this question a lot. We just don't want people to kind of go to that as their first choice.
Great question, Marina. Oh yeah, so Amy, she saw the question about AQO, but no, we have not released any details or just yet. Emily had just stated that we are hoping to share that information right after our annual meeting, our surgeon annual meeting that takes place this weekend. We are waiting on final details from our meetings team. And once our meetings team gives us the okay, all contracts have been signed, everything is finalized, we'll share all that information with you. Hopefully, shortly right after the annual meeting's completed this weekend. Marina says she's used it, but I get, why we would want to try not to. So yeah, absolutely. Yep, and you're welcome, Amy. Not a problem. All right. I do not see any additional questions. Again, monthly webinars for February 18 and March 18. Abby, there's a date and location for 2025 AQO on the STS website. Should we disregard? Emily, do you know anything about that?
Honestly, no, I don't. So thanks for telling us. Let's look at it.
Oh God. Yeah, let's look at it. Let's go see. Interesting. Let's see here. AQO.
Where do you see that? I guess.
Yeah.
I just put in the search box AQO 2025 and it came up.
Oh, good.
Oh, yeah.
All right, let's look. Okay, breaking news. It's on the website.
Breaking news.
Do you want to pull
Thanks,
it up
Abby.
and show them?
All right, thanks. Okay, so apparently
Apparently it's out there.
it's out there. Thanks for
I'm
letting
sorry. Our
Okay,
meetings
great.
person did not tell us that. So they've been telling us that we would be able to update after the annual meeting, but it's up there now. Great.
Beautiful. So breaking news. AQO 2025 is being held in San Antonio, Texas, and the dates are October 1st through the 3rd. So there's that. So beautiful.
More information on the price to come. We will have that discussion internally. Probably we usually have that in the spring. But I would say if you're budgeting, try to budget for around the same price that it was this year. And then we are planning to have a virtual pass like as we did last year. So virtual pass with information on the virtual platform with content that will be posted there, and then we'll also have an in-person, as you can see, option as well. So that's my update.
All right. Oh, Lordy. Yeah, thanks for letting us know. We appreciate it. Oh my gosh. So sorry about that, guys. All right. So again, for those just joining us, late breaking news, AQO 2025 will be in San Antonio, Texas. And the dates are October the 1st, and we will share more specific details ASAP. Okie dokie. Let's see here. Wait, all right, more questions. Okay. Here's the date. Okay, yep, thank you, Abby. Risk adjusted, nice catch, Abby. Okay, will there be a virtual option? Yes, there will be a virtual option for AQO 2025. Not a live streaming option, but again, the virtual option like like we have in the past, Kate. Let's see here. Let me see if I can get the risk adjusted dashboard report resource to download. Sorry, guys. But yes, I do have a moment to go over that. See if I can download it. Let's see. Okay, there we go. All right, so yeah, so for you guys that are not familiar with this document, so there is a risk adjusted dashboard report calculation resource document that IQVIA prepares for us, or that has prepared for us. So if you're wondering how, we determine, how the calculations are done for specific tables, all of that information is found here. This is a very big document. I don't have time to go through everything for all of these. There's a lot of information out here within this document. So all I can say is just, if you have time, feel free to download it and go through it. But you'll see here at the bottom, there are tabs for each of the reports that are available out on the IQVIA platform. You have information for table 1, how the the calculation is the calculation that is used for each of the variables. Up at the top, you have the calculation, you have the category, the name, all of the information here. Again, there's just a lot of information out here. Same thing with table 7. For, like I said, each of the tables are here. I think these tabs that are highlighted are where the most recent updates have occurred. Yes, so the tabs that are highlighted, so if you have a previous version, the tabs that are highlighted have the changes, for this updated version, so you can see what's changed from the previous version of the document to the current version. So just go through the benchmark operations table. You can see here that this was updated. You can see the information that was added here for the benchmark codes. Same thing for the table 19, table 5. Again, all of the information here, all of the lesion specific tables. This is, like I said, it is a very detailed and it can be very overwhelming document, but all of the information of how these numbers are calculated are located in this document. This document honestly gives me, Chas, Leslie, Dr. Subramanian, PTSD. The amount of hours and time we have spent reviewing this document and going through it is just, I can't even begin to describe how overwhelming, how much time we've spent on this. So if you have questions, please feel free to, send them. I'm happy to answer anything that I can. But again, this document is out here and available for you for your download and review. Chas, Les, did you guys have anything you wanted to share about that document other than the fact that we all have PTSD from it?
True, but we will talk about that document as well as the analysis overview document in that webinar that we discussed briefly today about that will happen kind of after the reports come out. So we'll talk about, if you're looking at a table, how to find what went into the table using that spreadsheet, and what is also described in analysis overview.
Yeah, and thank you, Aaliyah. She had mentioned she finds it extremely useful to explain to their surgeons and anesthetists how the benchmarking report tables are calculated. So I think she uses that in some of her, obviously in some of her meetings with her team. So thank you. I'm glad you find it helpful. So
I would just add, Leanne, that it's the first thing I go to when I think a case should be in a table or a patient should be in a table and they're not. It's the first resource that I use to say, okay, they had this procedure, they have this diagnosis, would they belong in this table? So especially helpful with our new combination codes.
Yes, the lesion specific tables, very much so, yeah.
Because not all of them are included. And so again, much more detail to come in the new data manager webinar, but
right. Yeah, all of for the lesion specific tables, again, up here, as Chas was saying, are the required primary diagnosis and primary procedures for those tables. So you'll find that information there. And then down here in the details, a lot of details about each specific calculation that is done. All of the logic is here for the specific calculation. So again, a lot of information here. Feel free. Like I said, it's a great resource. So it's very helpful. All right. Let's see here. All right, I've got about 1:52 Eastern time. I'm not seeing any additional questions come in. So with that, I guess we'll end a little early today, give you guys a few minutes back. But again, if you have questions, please don't hesitate to reach out to us. We are here to help you and answer any questions that you have. More details on AQO coming soon, more specific details other than location and dates. Emily and team will share that as soon as possible. And thank you all for joining us today. Thank you, Chas, Leslie, for your phenomenal education. I appreciate you guys more than you know. So I hope you guys enjoyed today's webinar, and I should have everything PDF'd and over to our marketing team for posting. Hopefully they'll have it posted by the end of this week. So just look out there if you need the slides, and reach out if you guys have any questions. Thanks everybody for joining today. Hope you guys have a great rest of your week. Stay warm. And for those of you that don't get snow often, I hope you enjoy the snow. So thanks everyone. Hope you have a great day. Bye-bye.